The real cost of Oklahoma healthcare is time. Oklahoma's shorter life expectancy means fewer graduations, weddings, holidays, and fewer years watching grandchildren grow up. Most grandparents do not measure life in government statistics. They measure it in birthdays, graduations, weddings, holidays, and the privilege of watching a grandchild grow into an adult. But Oklahoma families are receiving less of that time. First, the United States trails many other developed countries in life expectancy despite being wealthier than most of them and spending far more per person on healthcare. Then Oklahoma falls nearly 4 additional years below the national average. According to the Centers for Disease Control and Prevention, life expectancy in Oklahoma was 73.8 years in 2022. It was 71.3 years for men and 76.5 years for women. The national average was 77.5 years. 27 OECD countries had life expectancies above 80 in 2023. People in countries including Japan, Spain, and Italy live longer than Americans, even though those countries are less wealthy per person than the United States. Put America's international disadvantage together with Oklahoma's additional disadvantage, and the result is roughly a decade of life separating Oklahomans from people in some developed countries with universal health care. Life expectancy is a population average, not a prediction of when any particular person will die. But Oklahoma's underlying mortality data tell an equally troubling story. Approximately 1/3 of Oklahomans would not survive to age 70 under the state's 2022 mortality rates. For men, the figure was nearly 39%. This is not merely a statistic. It is a grandparent missing a graduation, a father absent from a wedding, a family gathering with an empty chair. Living in one of the world's wealthiest countries should provide a longevity advantage, not a disadvantage. But America is failing to convert its extraordinary wealth and healthcare spending into longer lives. Access remains tied to income, employment, insurance networks, deductibles, and the ability to absorb a large medical bill. The wealthiest Americans can generally purchase more options. Millions of working families cannot. Other advanced economies spend less, cover nearly everyone, and live longer. America spends more while leaving many people to postpone treatment, skip prescriptions, remain in jobs for insurance, or discover that having coverage does not necessarily make care affordable. The international comparison does not prove that universal health care would automatically give every Oklahoman another decade. Smoking, poverty, addiction, nutrition, education, and rural access also affect longevity. It demonstrates something more important. America's wealth should be helping its people live longer. Instead, much of that advantage is being consumed by the world's most expensive healthcare system. Oklahoma's Republican congressional delegation generally presents universal health care as a threat to freedom, choice, and private enterprise. Their statements deserve to be considered, but they also deserve serious counterpoints. If I can control your health care, then I can control you. Hearn has used that argument to oppose what he calls European-style socialized medicine. But control over American healthcare already exists. Employers decide which insurance plans workers may purchase. Insurance companies determine networks, prior authorizations, and covered treatments. Pharmacy benefit managers influence which medications patients can afford. A worker who becomes seriously ill may discover that leaving a job also means losing access to doctors and treatment. Which arrangement provides more freedom? Healthcare that follows the individual, or healthcare that can handcuff a sick worker, or the parent of a sick child, to an employer? Lankford has called Medicare for All a government takeover and a radical position. He has also warned about the possible effect of reimbursement changes on rural healthcare providers. Protecting rural hospitals is a legitimate concern. But Oklahoma's rural healthcare system is already struggling under the present arrangement. Universal coverage is not an untested idea. Nearly every other developed country has found a way to guarantee or nearly guarantee coverage, although their systems differ substantially. The question is not whether every universal healthcare proposal is perfect. It is why Oklahoma should remain committed to a system already failing many rural communities. I strongly support a role for private enterprise in American healthcare. That statement suggests a choice between private enterprise and universal coverage. Other countries demonstrate that this is a false choice. Universal coverage does not require government ownership of every hospital or employment of every doctor. Countries use non-profit insurance funds, regulated insurers, private physicians, and independently operated hospitals. Universal healthcare describes the guarantee that people receive coverage. It does not prescribe one particular delivery system. Lucas has opposed what he described as a government takeover that would place bureaucrats in Washington between patients and doctors. Yet American patients already confront an enormous private bureaucracy between themselves and their doctors, insurance networks, claims departments, prior authorization reviewers, pharmacy benefit managers, and billing contractors. The United States has not eliminated healthcare bureaucracy. It has privatized much of it and pays more for it than any other country. Burchine has argued that America must reduce the middlemen in healthcare. That is a worthwhile goal. But private insurance companies and pharmacy benefit managers are among the most powerful middlemen in the current system. Each insurer maintains separate contracts, networks, rules, billing requirements, and drug formularies. If reducing middlemen is the objective, Oklahoma voters should ask why preserving the insurance industry's central position is treated as non-negotiable. BICE has emphasized private coverage options, competition, and patient choice. But most employees do not choose among every insurance company or health plan in the marketplace. Their employer selects a limited menu. Changing jobs can mean changing doctors, networks, deductibles, and drug coverage. A system in which healthcare follows the person would increase employees' freedom to choose where they work, even if private doctors and hospitals continued providing their care. Tedford has stated, Medicare and Medicaid should remain available for seniors and the truly vulnerable, but Washington should not ever take over healthcare. I support patient choice, price transparency, competition, and lower costs through free market reforms. Tedford's position is clear. But universal coverage does not necessarily mean Washington takes over hospitals or medical practices. It means no American loses access to healthcare because of unemployment, reduced hours, a job change, or an unaffordable deductible. Tedford has worked in insurance since 1992. Oklahoma voters are entitled to ask whether he would consider any universal system that preserved private providers and patient choice, or whether preserving the insurance industry's current role is itself the priority. Arguments about government control avoid the most important question. What are Americans receiving for what they spend? The OECD estimates that the United States spent approximately $14,885 per person on healthcare in 2024. The OECD average was approximately $5,967 per person. The difference was $14,885 minus $5,967 equals $8,918 per person, applied to approximately 340 million Americans. $8,918 times 340 million equals approximately $3.03 trillion. That gives us the central spending comparison. If the United States reduced its per-person healthcare costs to the OECD average, America's total healthcare bill would fall by approximately $3 trillion annually. The OECD average is a benchmark, not a fully designed American budget. Its members have different populations, benefits, and systems. America could not reduce its healthcare prices overnight, but even allowing America to spend considerably more than the OECD average produces enormous savings. Suppose an American universal system spent $7,500 per person, approximately 26% more than the OECD average, to provide comprehensive medical coverage, prescription drugs, essential dental care, and limited cost sharing. That would cost approximately $7,500 times 340 million equals $2.55 trillion annually. Compared with more than $5 trillion in current American healthcare spending, the potential savings would still be approximately $2.5 trillion every year. Even at $9,000 per person, more than 50% above the OECD average, America would spend approximately $3.06 trillion and could still save around $2 trillion annually. The conclusion is difficult to avoid. America could spend substantially more than the OECD average, cover everyone, and still save between $2 trillion and $3 trillion a year. Universal health care would require tax financing. Hospitals, doctors, dentists, and drug manufacturers would still have to be paid. But for most working families and businesses, the new healthcare tax would replace a larger combination of insurance premiums, employer contributions, deductibles, co-payments, and medical bills. The relevant question is not whether a new tax would appear. It is whether that tax would be smaller than the private healthcare costs that disappear. Federal, state, and local governments already finance approximately $2.5 trillion in annual healthcare spending through Medicare, Medicaid, Veterans Healthcare, public employee benefits, and other programs. That includes Medicare spending financed partly by the payroll tax already withheld from workers' paychecks and matched by employers. Under universal health care, existing Medicare taxes could continue financing the expanded system or be incorporated into a replacement tax. They would not be ignored and then charged a second time. Households, businesses, and other private sources finance approximately another $2.6 trillion to $2.8 trillion. That private burden includes employer insurance contributions, employee payroll deductions, individually purchased policies, Medicare premiums, prescription drug premiums, dental insurance premiums, deductibles, co-payments and co-insurance, uncovered medical, drug, and dental bills. America does not need to find an entirely new pot of money for healthcare. Americans are already paying the bill and then some. The median American household earned $83,730 in 2024. Consider a four-person household earning that amount and receiving family insurance through an employer. The average family policy now costs $26,993. The employee pays approximately $6,850. The employer contributes approximately $20,143. A covered worker with a general deductible faces an average deductible of $1,886. Co-payments, co-insurance, prescriptions, and dental expenses come on top of those amounts. For a family that uses enough care to meet the deductible, the employee premium and deductible alone can total $6,850 plus $1,886 equals $8,736 annually. Under one previously proposed financing illustration, households would pay a 4% healthcare tax on income above a substantial exemption. Applying that structure to a household earning $83,730 would produce an estimated annual tax of approximately $2,200, although the actual amount would depend on the final exemption and tax schedule. The illustrative calculation looks like this. Median income household, annual amount, employee family premium eliminated $6,850, average deductible eliminated or sharply reduced, $1,886. Direct costs eliminated before co-payments, $8,736. Illustrative household healthcare tax, about $2,200. Potential additional disposable income, about $6,500. That is approximately $540 a month. It could help make a mortgage payment, finance childcare, replace an aging vehicle, pay down debt, or build retirement savings. The calculation does not include additional savings from co-payments, co-insurance, prescription expenses, or dental care. It also does not assume that any of the employer's $20,143 insurance contribution eventually returns to the worker as higher wages. The Congressional Budget Office recognizes employer health benefits as part of workers' total compensation. If competition for labor caused even part of those employer savings to return through wages, the family's eventual gain could be larger. Now compare that potential benefit with the One Big Beautiful Bill Act. The Tax Policy Center estimates that households earning approximately $67,000 to $119,000, the income group containing the national median household, receive an average 2026 tax reduction of about $1,800 under the law's tax provisions. Our illustrative median income family could gain approximately $6,500 from replacing its employee premium and deductible with the healthcare tax described above. Competing policies, estimated annual benefit, BBB tax reduction for a middle-income household, about $1,800. Universal health care illustration, about $6,500. Additional potential health care benefit, about $4,700. Universal health care could therefore provide approximately 3.5 times the direct financial benefit of the BBB tax reduction. The BBB does provide tax reductions to many middle-income households. That should be acknowledged, but its largest dollar benefits flow upward. The Institute on Taxation and Economic Policy estimates that the richest 1% will receive an average tax reduction of approximately $66,000 in 2026. The richest 5% receive approximately 45% of the law's net tax benefits. The richest 1% receive more total tax savings than the entire bottom 60% combined. The Tax Policy Center estimates income group average 2026 tax reduction, lowest income households about $150, middle-income households about $1,800, households earning $460,000, $1.1 million, about $21,000, highest income 0.1%, nearly $300,000. Those figures measure the tax provisions. Once reductions in Medicaid, food assistance, and health insurance subsidies are considered, the Congressional Budget Office finds that resources decline for households near the bottom while increasing for households in the middle and at the top. Oklahoma's congressional Republicans supported a policy offering a middle-income household an average tax reduction of approximately $1,800 while preserving a health care system that can take several times that amount back through premiums, deductibles, and medical bills. That is not an abstract ideological difference. It is a choice about who receives the larger benefit. Suppose America spent $7,500 per person on comprehensive universal health care, 26% above the OECD average, and saved approximately $2.5 trillion annually. What else could the country do with even a fraction of those savings? Approximately 9 million students could potentially benefit from 2 tuition-free years at a community college or technical school. Using an estimated tuition cost of approximately $4,000 to $5,000 per student, the national cost would be roughly $36 billion to $45 billion annually. That is less than 2% of the potential healthcare savings. America could provide 2 tuition-free years of college or technical training and still retain approximately $2.45 trillion in annual savings. Those 2 years could prepare Americans for careers in nursing, welding, advanced manufacturing, computer technology, aviation maintenance, construction trades, medical technology, energy, automotive repair. That is the difference between spending and investment. Excessive healthcare prices consume family and business income without producing better national outcomes. Education and technical training increase skills, productivity, and earning power. Tax cuts ask ordinary Americans to wait for economic gains to trickle down. Lower healthcare costs and workforce education invest directly in their ability to move up. One of the least discussed costs of employer-sponsored insurance is job lock. Workers remain in jobs because they or a spouse or child need the health plan. They pass up higher-paying positions, avoid starting businesses, or delay retirement because changing employment could mean changing doctors, losing drug coverage, or beginning a new deductible. The Government Accountability Office has found evidence that employer-sponsored insurance reduces job mobility, self-employment, and retirement. In one analysis, men with employer coverage were approximately 23% less likely to leave their jobs when they lacked access to coverage through a spouse. The Congressional Budget Office has also recognized that access to insurance outside employment can help workers move to jobs that better match their skills. Healthcare tied to employment does not merely limit medical choice. It limits economic choice. A worker should not have to choose between a better future and a child's oncologist. The Affordable Care Act generally defines a full-time employee as someone averaging at least 30 hours a week or 130 hours a month for purposes of the employer coverage requirement. That creates an incentive for some businesses to control workers' hours and avoid crossing the threshold that may trigger healthcare obligations. Universal coverage would not eliminate every reason employers use part-time labor, but it would eliminate the health benefit incentive to keep a worker below a particular number of hours. That matters in Oklahoma. A June 2026 Government Accountability Office analysis of September 2025 Medicaid enrollment estimated that Walmart employed 4,684 working-age Oklahoma Medicaid recipients and Amazon employed another 2,697. Together, those companies employed approximately 7,381 Oklahoma Medicaid recipients included in the study. McDonald's was sixth on the Oklahoma list, with approximately 1,533. The figures do not prove that any particular company illegally manipulated hours. They are estimates, are not adjusted for company size, and identify the employer of record rather than every circumstance affecting a worker's household. But they reveal the larger arrangement. Taxpayers finance healthcare for thousands of Oklahomans employed by some of the largest corporations operating in the state. Kevin Hearn's business career included operating more than 20 McDonald's franchises. That experience should give him a useful perspective on a basic policy question. Why should access to healthcare depend on whether a restaurant, warehouse, or retail employee receives 29 hours or 30? Universal coverage is frequently described as a new tax on employers. That framing ignores what businesses already pay. The average employer contribution toward a family policy reached approximately $20,143 in 2025. That is effectively a private healthcare tax, one that rises unpredictably and requires companies to administer benefits unrelated to their underlying businesses. Businesses should compare a universal healthcare contribution with their present premiums, not with zero. A company paying $20,143 toward a family policy is not receiving free market healthcare for nothing. It is sending a substantial portion of an employee's compensation to an insurance company. For many businesses, replacing premiums with a lower and more predictable contribution could reduce costs, simplify administration, and make it easier to compete for workers. It would also eliminate the competitive advantage available to companies that limit hours or rely on Medicaid to cover employees. Opponents describe universal healthcare as a threat to personal choice. But patients in other developed countries continue seeing physicians, receiving referrals, obtaining second opinions, and undergoing specialist treatment. The major difference is that illness is less likely to destroy everything the family has accumulated. A Canadian member of Parliament described being born with a cleft lip and receiving the necessary medical treatment. "We never had to worry about paying a bill." The speaker added that his parents never had to worry about whether he would receive the treatment he needed. Canada has serious waiting time and physician shortage problems, especially in some rural communities. Prescription and dental coverage vary by province. But Canadian families generally do not receive American-style bills for medically necessary hospital and physician services. A family does not have to wonder whether a child's surgery will consume the parent's retirement savings. Sue, a 59-year-old British cancer patient, had previously survived breast cancer. When an enlarged lymph node appeared, she sought further investigation through Britain's National Health Service. After an initial diagnosis suggested her cancer was terminal, Sue and her consultant obtained a second opinion. A second biopsy revealed a different diagnosis, one that could be treated. She underwent specialist surgery to remove 26 lymph nodes and then received radiotherapy. Her advice was, advocate for yourself and trust your instincts. Sue questioned a diagnosis, obtained a second opinion, saw specialists, received surgery, and underwent radiation treatment. She did not have to remain silent because another opinion fell outside an employer's insurance network. Japanese economic commentator Hajime Yamazaki was diagnosed with stage 3 esophageal cancer. He underwent 2 hospitalizations for chemotherapy followed by surgery. After experiencing the system personally, he said, "I became convinced again that cancer insurance was unnecessary. Japan requires patient cost sharing, but its national health insurance system places income-related limits on catastrophic medical expenses. His treatment was not entirely free, but its cost was not unlimited. That is the critical difference. A family can plan for taxes or capped copayments, It cannot responsibly budget for a six-figure cancer diagnosis. No universal system guarantees that every patient immediately sees any specialist in the country. Canada struggles with waiting times. Britain's NHS has experienced staffing and capacity shortages. Japan requires patient contributions. Other OECD systems have their own weaknesses. But neither does the American system guarantee immediate access. Americans wait for specialist appointments. Rural Oklahomans travel long distances for care. Insurance companies deny prior authorizations. Patients discover that physicians are outside their networks. Others delay treatment because they cannot afford their deductibles. America rations healthcare too. It frequently rations according to income, employment, insurance status, and the ability to pay. The honest comparison is not between an imperfect universal system and an imaginary perfect American system. It is between the problems other countries experience while covering nearly everyone and the problems America experiences while spending far more and leaving families exposed to financial ruin. Most Americans will never leave their children millions of dollars. Their generational wealth may consist of a paid-off home, a retirement account, a family farm, a small business, and savings accumulated during 40 years of work. A serious illness can consume that inheritance long before an estate tax return would ever be filed. Our earlier illustration showed a possible $6,500 annual gain for a median income household. If that family saved and invested half, $3,250 annually, for 30 years at an average 5% return, it could accumulate approximately $216,000 in additional family wealth. Saving the entire $6,500 under the same illustration could accumulate approximately $432,000 over 30 years. Those are illustrations, not investment guarantees. But they show that recurring healthcare expenses cost families more than this year's premiums. Families also lose the investment growth that money might have produced over several decades. Universal healthcare could help ordinary families build and preserve hundreds of thousands of dollars in additional wealth while protecting them against catastrophic medical bills. Healthcare reform is therefore more than a medical policy or household budget policy. It is an estate protection policy for families who will never need a high-priced estate attorney or a multimillion-dollar trust. Medical treatment and prolonged custodial care are not the same thing. Medicare generally does not cover extended nursing home residence when someone primarily needs help bathing, dressing, or eating. Medicaid may cover long-term care after a person meets financial eligibility requirements. If America intends to protect family assets fully, a universal plan must say explicitly how it handles hospital and physician services, specialist treatment, prescription drugs, essential dental care, home-based assistance, long-term nursing home care. Otherwise, medical coverage could become universal while nursing home costs continued consuming middle-class estates. The broader goal should be clear. America should protect families against both medical bankruptcy and long-term care costs capable of consuming a lifetime of savings. Republicans insist that families should be able to pass what they have built to their children and grandchildren. The One Big Beautiful Bill Act increased the federal estate tax exemption to $15 million for an individual and potentially $30 million for a married couple beginning in 2026. Those amounts will be indexed for inflation. The Congressional Research Service reports that the federal estate tax affects only a tiny fraction of deaths. Yet protecting multimillion-dollar estates was important enough for congressional Republicans to preserve the increased exemption. Why does that principle disappear when the estate belongs to a middle-income family? Doesn't the family with $300,000 deserve to protect its life's work too? Family Congress protects, protection provided, individual transferring up to $15 million, no federal estate tax. Married couple potentially transferring $30 million, no federal estate tax. Middle-income couple with a home and retirement savings, exposed to premiums, deductibles, uncovered care, and long-term care cost. If preserving generational wealth is an important national objective, it should not begin when a family reaches $15 million. A universal healthcare system could protect the smaller estates representing nearly all the wealth ordinary families will ever pass to the next generation. That would do more to create broad-based generational wealth than shielding the next $1 million above a multimillion-dollar estate exemption. A government that protects a $30 million estate but allows illness to consume a middle-income family's life savings is not protecting generational wealth. It is protecting wealth after deciding whose wealth matters. These are not requests for another recital about socialism, government control, or the free market. Oklahomans have heard those slogans for decades. These are requests for numbers and results. You have said, "If I can control your health care, then I can control you," which arrangement gives workers more control. Universal coverage that follows them, or employer-sponsored insurance that can prevent someone with a sick spouse or child from accepting a better job. You have described Medicare for all as a government takeover and a radical position. If other developed countries cover nearly everyone for an OECD average of approximately $5,967 per person, why should Oklahomans accept an American system costing approximately $14,885 per person without receiving universal coverage or longer lives? You strongly support a role for private enterprise in American healthcare. Why must protecting private enterprise require preserving a system in which insurers, employers, and pharmacy benefit managers restrict networks, require prior authorization, and stand between patients and their doctors? You have warned against putting Washington bureaucrats between patients and doctors. How are patients freer when insurance company claims reviewers, network administrators, and pharmacy benefit managers already decide which doctors, treatments, and prescriptions they can afford? You have called for reducing healthcare middlemen. If private insurers and pharmacy benefit managers are among the largest middlemen in healthcare, why should their central position be protected instead of creating portable coverage that follows every American? You have emphasized competition, private coverage options, and patient choice. How much real choice does a worker have when an employer selects the available plans, and changing jobs can mean losing doctors, drug coverage, and progress toward a deductible? You have said Washington should never take over healthcare and that free market reforms will produce greater choice and lower costs. What evidence shows that further market reforms can close a per-person spending gap approaching $9,000 while covering everyone? And would you consider any universal system that preserved private doctors and hospitals? Assigning one question to each person does not relieve the others of answering it. Every Oklahoma representative, Senator Lankford, and congressional candidate Mark Tedford should answer all 7 questions. They should also answer these. How would your preferred plan reduce American healthcare spending from $14,885 per person toward the OECD average of $5,967? How many additional years should Oklahomans accept a life expectancy nearly 4 years below the national average? What is your plan to prevent illness from consuming a middle-income family's home, retirement savings, and intended inheritance? Why is preserving employer-sponsored insurance more important than allowing healthcare to follow workers between jobs? How much would your proposal save a 4-person household earning the median household income? Would it reduce premiums, deductibles, prescription expenses, and dental costs? By how much? If universal health care threatens economic opportunity, why does the United States rank below numerous universally covered countries in economic mobility? Why should taxpayers finance Medicaid coverage for thousands of people employed by some of America's largest corporations? If Congress can protect an inheritance of $15 million per person or potentially $30 million per couple, why shouldn't it protect the smaller estates illness can take from ordinary families? What measurable result should voters expect from your alternative? And when should they expect it? These officials did not invent the Republican Party's healthcare position. They inherited and continue defending it. For decades, Republican healthcare policy has relied on familiar arguments. Employer-sponsored insurance protects individual choice. Competition will eventually lower prices. Universal coverage gives government too much authority. Tax reductions create more opportunity than expanded public benefits. Medicare, Medicaid, and other public programs should remain limited, rather than become the foundation of universal coverage. The personalities change. The vocabulary changes slightly. The promised market solution remains just around the corner. Meanwhile, America continues spending nearly $9,000 more per person than the OECD average. Oklahoma continues falling behind the nation in life expectancy. Families remain tied to jobs for insurance. Businesses pay enormous premiums. Medical and long-term care costs threaten the savings ordinary people hope to leave their children. These 7 Oklahoma Republicans are responsible for their individual positions, but they also represent a long-standing party position. Preserve the private, employment-centered system and warn voters that universal coverage would be worse. That argument now carries the burden of proof. Universal healthcare advocates should be expected to explain benefits, financing, provider payments, and taxes. Republican opponents should meet the same standard. It is no longer sufficient to say government takeover, socialism, patient choice, or free market. Those are labels, not healthcare plans. If Oklahoma's Republican leaders believe their approach is better, they should provide comparable numbers: cost per person, household premiums, employer contributions, deductibles and copayments, prescription and dental expenses, number of uninsured people, rural hospital stability, medical debt exposure, effect on job mobility, expected improvement in life expectancy. Then voters can compare the results. The healthcare debate is usually presented as a contest among government, insurance companies, employers, and taxpayers. Families experience it differently. They experience it as time. Time to change jobs without losing a specialist. Time to start a business without gambling a family's medical security. Time to seek treatment before a manageable condition becomes a crisis. Time with your family, the most important thing our political leaders focus on when crafting our nation's and state's healthcare policy. Follow the money at wlangdon.substack.com. Follow the money at wlangdon.substack.com.